welcome to Health Issues. I'm your host, Chris Sylvain, and we're totally excited today, deeply honored. We have probably, I hate to use the word, but I'll say a superstar in terms of research and science. Dr. Vivian Fonseca. He's a past president of the American Diabetes Association. He's the chairman of the Department of Endocrinology at Tulane University. He's done extensive work, all around everywhere, and those in the medical community, I'm sure, know and heard of him, but we're excited to have him. Welcome, Dr. Fonseca.
Thank you for having me, Chris. It's a pleasure to be here.
We're definitely an honor for us. And the topic we're discussing is diabetes, and if you can just start off, tell us a little bit about it.
Well, diabetes is such a prevalent problem, and I've been working in this area a long time and seeing much change in it. It affects our community in New Orleans very seriously, right, and across the country. It's the leading cause of blindness, responsible for more than half of amputations, dialysis, all that. And it comes on very slowly. People ignore it till it's very late, and that's the tragedy. But we've got a lot of good news there as well, a lot of good studies with good results, and we're doing some new things to work on prevention, which I think is very exciting.
Yeah, a lot of people feel that it can't be prevented. They feel that, hey, their mother had it, their grandmother had it.
Well, type 2 diabetes is preventable to a good degree, just modest changes in lifestyle. You can't change your mother. But you can change your life a little bit. There's a study in people who are at very high risk, who they changed their lifestyle a little bit, walking 30 minutes a day.
30 minutes a day, okay.
And lowering weight by 5% by just simple calorie restriction. It wasn't a very difficult or challenging thing because a lot of people in the study did it.
Okay.
And it reduced their risk of getting diabetes in 3 years by 60%.
60%, that is huge.
For a 3-year period, I think that means you're pushing it away into the future and maybe never get it.
That's fantastic. Just 5% weight loss.
5% weight loss. I think that walking was also very important.
So it's not just 5% weight loss without the exercise.
With the exercise.
With the exercise.
Both together.
But if they did it without...
That was not tested.
That wasn't tested.
It was all part of the whole package of lifestyle change.
Okay, so 30 minutes a day, 5% weight loss.
And this was an NIH study. It's called the Diabetes Prevention Program. Our challenge today is to what I call translate it, getting this message out to people and getting everybody to do that. And I think we are not doing quite well there. We still have a lot of overweight people progressing onto diabetes, not doing these kind of things. Now, of course, there's some people who can't do it. If you're physically disabled, you can't walk 30 minutes a day. And for them, we have to look for other things. There's some people who do it, and still the disease is progressing because it's so strong in their families. And we have a lot of that there as well. And for them, we want to look for other ways to prevent diabetes beyond the lifestyle change.
Okay. Whereas, and just talking about it earlier, the 5% wouldn't work for them, or the 30 minutes a day wouldn't work. They would have to move to more extreme measures, possibly.
Yes.
Okay. Those extreme measures in weight loss, just
more weight loss, maybe surgical approaches or things like that.
Okay.
Now, people have been trying lots of other over-the-counter medications and other things like that, but nothing's been really proven to work.
Okay.
There's a drug for diabetes called metformin, which is now generic and widely used and pretty safe, but it's got side effects. It does improve the risk of diabetes, but it's never been approved by the FDA for preventing diabetes, approved for treating. So we are actually doing a very interesting study called D2D. It's sponsored by the National Institutes of Health, your tax money and mine. And we are trying to see whether vitamin D, over and above lifestyle change, will prevent diabetes.
And vitamin D is popular. Every doctor's prescribing it.
Everybody's taking vitamin D, but actually there are very few good long-term studies.
Okay.
This is a 5-year study. We will study vitamin, the impact of taking vitamin D.
Okay.
A fair amount of vitamin D.
Okay.
There's going to be a dummy pill as well. I mean, one or the other is what you will get. But we will screen people. We'll find those who are at risk for diabetes based on the screening. If they are pre-diabetes, put them on vitamin D or the dummy pill and follow them. And some will get diabetes. Then it's good to know you get onto treatment quickly. if you don't get diabetes and it all works, that's what we will all be taking in the future.
But as of now, there's not a whole lot of good information on.
None at all.
Even though
it's very debatable.
It's gone from
mixed. Some studies show benefits, some show the opposite.
Went from a drug that nobody even thought about prescribing, and all of a sudden now it's shot up to the top.
Well, of course, the best source of vitamin D is sunshine.
Hey,
I'm all for that.
It's easily, it's important that those studies are done.
Yes,
pure and simple. Absolutely. Yeah, very, very much so. So let's look at this concept of diabetes, and for the most part, it can be prevented for a lot of people if they're willing to do those things. So exercise we've spoken about, 30 minutes a day. Is
simple walking.
Simple walking.
But I think people could look beyond walking. Do something fun. If you like to ride a bike, you can ride a bike.
Okay.
If you want to go dancing, you can go dancing. I mean, that's
yeah.
exercise. Or you want to go to the gym, that's fine.
Whatever, so long.
Whatever suits you. But it's putting in some time every day into
breaking
exercise.
a sweat.
Yes, a little bit.
A little bit. Doesn't have to be total, but some type of breaking a sweat. Let's move on to the part that's even more complicated for people. Figuring out what to eat. What foods? If we had to pick, what are the most detrimental foods?
I think the most detrimental thing is excessive quantity of food.
Okay. All right.
No doubt about it. No matter what you have, if you have too much, it's not good for you.
Okay.
And it's very easy to judge that. You gain weight.
So you know.
That's right. If you're gaining weight, you're having too much food.
All right.
And that's bad for you. Obviously, some foods are very densely packed with calories, like fat.
Right.
Some foods, people really like refined carbohydrates. It's very easy to get it into you, and it gives you a boost, and you feel good for a short while. But and people tend to eat more of that.
Okay. Okay.
And they're sweet, and it's nice, but it's got its problems if you have too much.
Okay.
There are some foods that appear to be somewhat protective. Olive oil is an example.
Okay.
Nuts and whole grains and vegetables and fruits. People who have more of that tend to have less diabetes and less heart disease.
Calorie for calorie.
Calorie for calorie. It's very hard to judge the calorie for calorie because you get full when you have those fiber things. So it fills your stomach. You may end up having less calories. So there tends to be an automatic calorie restriction when you eat a lot of fiber.
Just the whole volume.
That's volume things, yes.
The volume. In other words, it's hard to eat a whole lot of brown rice.
Yeah, and carrots and celery and things like that. You fill yourself.
Yeah, if somebody gave you a bucket of celery, it's just so much you'll ever eat. Makes a difference. Well, so with that though, we look at the flip side. Like you say, whole grains, refined grains. So it's a big problem between those two.
There's a difference. I mean, the whole grains may have a little nutrients thing, but it's hard to identify which. But I think the fiber there is very protective.
Okay, the fiber does it. Liquids.
Liquids, particularly soft drinks, have a lot of problems. You get very quick calories. It gets into you very fast.
Okay.
It goes down fast, gets absorbed fast.
Okay.
And it is potentially problematic. There's a large number of drinks available that have a lot of calories, a lot of sugar, a lot of sugar substitutes like high fructose corn syrup which is very hard to prove in humans, but in animals is associated with problems.
Okay.
And juices. They've got some good things in the juice. There's vitamin C. It tastes nice. It's good. Antioxidant, whatever you want to believe in.
Okay.
But there's no fiber. You're taking the fiber out. A glass of orange juice comes from 6 oranges.
It's a lot of oranges.
It's a lot of orange. You wouldn't eat those 6 oranges.
You're right.
If you did, I think you'd be okay. But if you just drink the juice, your sugar goes up a little bit. We use it to treat low blood sugar, hypoglycemia.
Right. Because it is real quick. I mean,
yes, that's right.
Juice. So, all right. So that's juices. That's soft drinks. I guess the next one would be the idea of these 0-calorie drinks.
I don't think there's anything hugely wrong with those things. There's some controversies, but it's not the calorie difference and the weight difference. Putting on weight is much more with the full calorie
okay.
drinks.
Okay.
There are some people who are just not satisfied with the 0 calorie drink, so they tend to eat more.
Compensate.
Yes,
okay.
and compensate for that.
And so the weight would gain, even though they're not taking in calories, because they're eating more of other foods. Yep. They'll just grab other things and keep on going. That's interesting. So that takes that. So different levels of having trouble, but there are challenges. But that brings us to water, coffee, and tea, and all good. Coffee's good, tea is good.
Yes, but you can't be drinking tea and coffee all day to prevent diabetes. It's not practical. There's caffeine in there, so you can't have too much of it.
So it's challenging.
I think a lot of these things in moderation are very good.
Okay, interesting. Fantastic. Interesting. Now, the idea of fiber, though, I guess the fiber in and of itself is just a powerful product. Then, when we think about it, then.
Fiber in itself is slowing absorption of the calories.
Okay.
So you have a slower rise in blood sugar,
okay.
a slower response from the body in terms of production of hormones and things like that. So it's got that advantage.
Okay.
It might have some effect on the gut that we don't understand. We're really exploring things about the gut microbes, and you're providing a lot of nutrition because a lot of fiber is not absorbed.
Got it. Okay. Awesome. So looking at the body, though, so the distribution, tell us a little bit about the idea of the distribution of fat around the body.
Well, fat in the abdomen, which essentially often means fat in the liver.
Okay.
And fat in the pancreas. Those are the organs that are very important for sugar.
Okay.
And also, those people tend to put in some fat in their muscles as well.
Okay.
So that fat is turning over a lot. It gets inflamed. It produces a lot of substances that are bad for you.
Okay.
So we tend to focus on that. Now, we look for visceral fat by doing MRIs and research and things like that. That's not practical. Okay. There's a very simple way of knowing whether someone's got visceral fat. You look at them. They get fat around the waist. They're likely to have it inside the abdomen as well.
Okay. And so essentially you're dealing with the liver and the pancreas then?
Yes, there's fat in there.
Okay, and that fat is different?
That fat is more active and creating more problems, gets inflamed.
Okay. Now, you had mentioned too, the foods that we eat, though, just overeating in and of itself leads more to the visceral fat.
Eating more tends to lead to weight gain.
Okay.
When weight gain is rapid, or weight gain is going on for a long time, more accumulates in places that allow it to accumulate. So your abdomen has more room and allows more. And there's some people who are born with less fat in the periphery, and some people are born with more fat in their legs, and they can store it there, whereas people who don't have that store it in their liver.
So it's not, and I guess that goes to the next area. So it's not, genetics play a major part.
They certainly play a major part, yes. But it's an interaction between your genes and the environment that you live in.
Okay.
And your lifestyle.
So regardless of grandmother, the mother we can't get rid of, we can still make changes. Absolutely. We can change our environment.
You can change your environment, yes.
Based upon the grocery store. But most people actually don't do this, though. Am I correct? That, say lose 5 pounds, lose 5% of the weight. The success rate is not very high.
It's not great, and we'd like it to be better. And there are lots of programs out there, trying to encourage people to do things, various health clubs, the YMCA. There's a Beacon project that we have with the CDC in New Orleans, sending text messages to people to encourage people to be more active and eat healthy. But it's still not enough. There's still a lot of people out there with pre-diabetes who are going to get diabetes if they don't watch things. There are 100 million people like that in this country.
Wow.
And there are 30 million people with diabetes.
Well, let me throw this out. What about the old food guide pyramid? A lot of people blame that food guide pyramid. You think The information has been kind of rough.
I think it's very easy to blame things, but things have evolved, and you know, they change as more information comes along. It's based on information that's available at that time.
At that time, okay.
I don't think that those things are inherently bad or totally wrong or anything like that. They make some sense. I think it's what we got to find a way is to make it easier for people to do those things. Build the physical activity into your lifestyle.
Okay. Get rid of cars.
Have a car and then keep it in the garage and ride a bike to work.
Well, you know, but that's the controversy too. How much should the government or society do as opposed to personal responsibility?
I'm not in favor of the government making us do things. I'm in favor of society changing in a way. What the government may do is perhaps, and we're seeing it now in New Orleans, I'm very glad to see some bike lanes.
Great. That's
you know,
right.
I think that helps you make the right choice of having the bike lane there.
Well, that leads us to, I guess, New York, the experiments in New York concerning the big gulp drinks and limiting big gulp drinks and so forth, trans fats.
There are multiple studies about those things. Trans fats, I think there's very little controversy now that they're bad for you, for the heart. Okay. But if you give people large portions, they consume more than if you give them smaller portions. So there's a very strong basis for what Mayor Bloomberg was trying to do. Giving people, you take a serving with less, you will consume that and you leave the restaurant. You give them more, they will have that all and then leave the restaurant, which means they've consumed more calories. So I think there was a lot of sense there. I think people who objected to that didn't object to the science. There's no objection to the science.
Okay.
They object philosophically to the government and the mayor telling them what to do and what not to do.
Interesting though, because yeah, I guess you're right. You know, the force of it, but the results ended up being, you know, very, very solid because people being able to make that decision on limited information, and let's even go to food labels.
Let's face it, it's very unfortunate, but a lot of us make decisions that are not quite in our own best interests, are they?
Yeah, that's right.
So I think having some kind of way to do the right thing.
Okay.
Now, you don't always want it coming from the government.
Never.
But, you know, I think pointing people in the right direction is a good thing.
It's important. And take them by the hand and help them as much as opposed to using a big stick and saying, thou shalt not. Food labels, though. What tools do we have? Going to the grocery store. You go into the grocery store, trying to tell the difference between a refined grain and a whole grain is real complicated.
A lot of that information is now on the packets. There are lots of websites. There are a lot of apps that you can download to your phone to tell you about these things. So I think things are much better in that respect today.
Okay.
The problem I find is that it's the healthy people who are using all these, and the people who are not healthy are not. And it's very tragic, but it's true.
The healthy people just get healthier, and those who aren't,
that's right,
aren't the ones who even move to it. So help for them. Is there help for those who aren't helped, who are not accessing the websites and the apps and
unfortunately,
so forth?
right now there isn't, and we have to keep working at strategies to help them.
Okay. People thinking that who then becomes responsible then? The people are still responsible for their bad behaviors, obviously, but then I guess translation. Is there a way to translate? People feel confused about, hey, this is bad, everything's bad, so I might as well.
We have to keep getting the message out to people as what the right thing is to do, and we have to keep working and doing research on trying to find new things, new strategies.
Okay.
Like, you know, 10 years ago, we discovered this thing. It sounds very simple, but it was like a discovery of the 30-minute walking. You know, we didn't really know that it would help, but it helped.
Okay.
By doing a study. We have to thank the volunteers in that study for doing that, because there was a group of people who did not volunteer to do that. They volunteered to carry on doing things as usual. And they were given advice, go and lose weight, use a diet sheet, whereas the other people were told, restrict your calories 5%, walk 30 minutes, and they did that.
You're a researcher. Tell us a little bit about this concept of, because a lot of people are afraid of research studies. You know that it's important.
You know, they've got a bad reputation in the past because things were not formalized well. And, you know, I'm talking many years ago. Studies were not done in a totally ethical manner. But now there are lots of safeguards. Every research study goes through an ethics board. There are people who are monitoring it, safety boards that are monitoring and keeping an eye on things. So we are very involved with clinical research. That's patient-related research at Tulane. And we have a number of studies. And I personally am very glad we got involved with this thing. We've done so many different studies that have led to new exciting treatments for people with diabetes, new strategies, heart disease, prevention of heart disease. And I think it's very important to do these. It's very important for people to participate so that they get monitored. So there actually is lots of evidence that people who participate have better outcomes.
Okay. Great.
And they are watched very closely in the study. I mean, we have a responsibility to follow the protocol, check them out, do the test, which you otherwise wouldn't do. So this study we're doing, I told you about the vitamin D, we're screening people for diabetes.
Right.
We're going to check them every 6 months to see whether they get it or don't get it.
Right.
Now, that is something that these people may not otherwise have done.
Okay.
They wouldn't know that they have diabetes for maybe 5–10 years, and it would be picked up here. So I think that it actually helps people in some ways.
Now, you are part of the ACCORD study you were talking about. It was a major study.
Now, ACCORD was a major study. Again, an NIH study, took 10,000 people across the country in the late stages of diabetes. Okay. And tried to make their sugar normal, their blood pressure normal, their glucose normal, their cholesterol normal, and it actually did not. In fact, if anything, people who were getting near normal were actually having a little bit of an excess mortality. It was a big puzzle.
It did the right thing.
It didn't help the heart attack things. It helped the eye damage and the kidney damage and those things related to diabetes. So there was some benefit, but there was also these risks. And it may relate to the fact that those people had had diabetes for a long time. They already had complications. So we're treating them too late. There are other studies that show that if you treat early, people do very well. So that, you know, I think it's very important to have your diabetes diagnosed well in time and start treatment seriously right at the beginning.
Start early.
Start early, keep it under control, have it monitored, and then you'll never get the problems. You'll never get the blindness or the amputation or kidney failure.
You just have to start early.
You start early and keep it monitored. You have to know your numbers and get it done.
So things people should look for is waste.
That's actually the good news about diabetes.
Okay.
Yes, waste and your weight and all that, but there are blood tests that you can do. You can go to the doctor and have a check your blood pressure, check your cholesterol, check your A1C.
All right. And
we are seeing now for the first time in the United States a fall in the rate of blindness, rate of kidney failure, dialysis, and rate of amputations, all fallen in the last 3 years. Really? That's after 10–15 years of all this research being translated across into practice. However, although the rate is lower, the number of people having the problem is going up because so many people have diabetes.
So diabetes is still like an epidemic.
So that's why I'm emphasizing prevention and new ways, look for new ways to try and prevent it. And then once you have it, you have the right treatment. And again, we did many trials at Tulane and found many new treatments. There's so many different treatments, but we don't know which is better than the other.
Really?
So there are all these treatments there. Some are more expensive, some are cheaper, some are injections, some are pills, but we don't know which is better for the patient in the long term. And we need to know that. So again, we've had a push from the government and others in that to do what we call comparative effectiveness research. You've got to compare them. So we are doing another study, also funded by NIH, for people who are taking metformin and fail on it. And we are comparing the different treatments that are available. No experimental medications. These are treatments that if you go to the doctor, he'll give you one prescription, very often by chance, what he thinks is good for you today. But he doesn't know that the other one may be better. Nobody knows. We need to find out.
But people hate going on the needle. I mean, you know, it's like, they don't want the needle.
But you're talking about insulin. Some of the best outcome studies are done with insulin, and excellent outcomes.
Okay.
And the needle isn't so bad. They're now fine needles with pen injectors, so easy to do, hardly hurts.
Okay.
Virtually no pain.
Virtually no pain. Yeah. That's it. But that's, people are afraid. But if they need to do that to bring the blood sugar in order, it's important. Glucophage, metformin and the other products. Metformin is just not that much better.
Metformin is the first-line treatment because it's actually very effective, and it is cheap and generic.
Right.
It does have some issues with some tolerability. Some people get stomach bloating and diarrhea and things like that.
Right.
But it's safe. There's nothing serious unless you got kidney problems or something. So for most people, it's pretty good. But it fails over time.
Really?
So you have, it doesn't, the disease progresses. So what do you add next is the key question we're answering in this study called GRADE. We don't know what is the best thing to add next. So we're comparing 4 different medicines.
We have a couple of minutes left, and just kind of want to wrap it up. But one thing I want, real quickly, does the pancreas just fail with diabetes?
Going down.
It keeps going down. You have insulin resistance, but really that pancreas...
It's the pancreas not working. It keeps getting worse and worse and worse.
Because it's as a workhorse, it just can't keep running hard. Sooner or later. Let's go ahead on and your last point, to drive home to the people, whatever you think is most important.
Well, I'm glad to be here, excited to tell people about diabetes. Maybe I'll come back again some other time.
Yes, you will.
It's a bad disease. Prevent it. When you got it, treat it well, treat it early. And we are trying to find the right treatment for the right person. That's really what all this is about, to prevent it right, treat it right. And I'll give you a number for if anyone's interested to call for this. It's 988-0200, 0200, 988-0200.
988-0200. They want to find out. They can find out more information about
these prevention and treatment studies.
And studies, everything. They can call those 988-0200, and that would be an opportunity for them to learn concerning diabetes. Dr. Fonseca, totally excited. Great information. People, work as hard as you can. 30 minutes of walking, 30 minutes of exercise, whatever you want to do it. And also, eat right. Pure and simple. Work as hard as you can, fight hard. Thank you so much.
Thank you.